Major funding for these broadcasts is made possible by grants from Chase Commercial Term Lending and New York Community Bank, M&T Bank, Perfect Building Maintenance, Capital One Bank, the Witkoff Group, Greenberg Traurig, Genova Burns. Additional funding is provided by grants from AKA Hotels, Corman Communities, Aerial Property Advisors, AVR Realty Company, Bank of America, Merrill Lynch, Bank Leumi USA, Briarwood Organization, CBRE, Citizens Bank, Colliers International NYC, CPEX Real Estate Services, Cushman & Wakefield, Customers Bank, DDG, Dime Savings Bank of Williamsburg, Fisher Brothers, First Nationwide Title Agency, Flushing Bank, Foley & Lardner, Friedman, Handler Real Estate Organization, HAP Investment Developers, Investors Bank, James D. Kuhn Real Estate Institute at Syracuse University, James Orphanides, Chairman USRealty.com, Kilroy Architectural Windows, New York's Window Company, Madison Realty Capital, Massey-Knackel Realty Services, Matone Group, Mercantile Commerce Bank, N.A., Meridian Capital Group, Newmark Grubb Knight Frank, Newbanks, MHP Real Estate Services, Optimum Window Manufacturing Corp., People's United Bank, Rosewood Realty Group, SJP Properties, Sterling National Bank, Sterling Risk, Stonehenge Partners, TD Bank, Terra CRG, the Continuum Company, the CUNY TV Foundation, the Moynihan Group, and these friends.
Healthcare in the 21st century. It's changed. I mean, you used to go to a hospital, you spend days there. Who heard of an ambulatory care center? Who heard of a surgery center? Who heard of, multidiscipline facility? The world of healthcare has changed, and today I've brought together the team who's really changing the way healthcare is practiced in New York City and the region. My guests today are Dr. Robert Grossman, who is the Dean and CEO of the NYU Langone Medical Center and the Dean of the NYU School of Medicine. Dr. Robert Press, who is the Chief Medical Officer and Chief Clinical Practice Head at the NYU Langone Medical Center. And last but not least, Dr. Andrew Brotman, who is the Senior Vice President and Vice Dean for Clinical Affairs and Strategy. So you've been at NYU how many years, Bob?
I went to medical school there from 1967 to 73, so I have an MD and PhD. Then I left for my house staff training, and I came back after my fellowship in infectious diseases in 1978.
You're the one who has the seniority, okay? Andy came over in 1999, Bob came over in 2001. How has the institution changed? Everything was the Tisch Hospital. The fact at that time, faculty practice was small. What's going on today? How have you seen the evolution over the last 30 years?
It's totally different. When I started, the focus actually was on Bellevue Hospital. That the NYU doctors do service at Bellevue. They're the doctors that really are providing care at Bellevue, and the focus from an administrative standpoint was on Bellevue, and we had the University Hospital, which was really there for the voluntary physicians that taught at Bellevue to admit their patients.
You came in 2001 as the head of radiology, and 2007 as the dean and CEO. How do you see the world today, and where do you see the world in the next couple of years? Because today you have a 705-bed university hospital. You're in the middle of major construction and expansion.
Well, we have the 705-bed hospital is the Tisch Hospital.
It's the Tisch Hospital, and then you have the Joint Disease Hospital and the other.
Right. So Well, we see the future of healthcare, as you said in your introductory remarks, is really on the ambulatory side. So we think that patients, the vast majority of patients, will be treated in very short stay episodes with only the highest acuity needing significant hospitalization. We are engaged in bringing medical services to the community and have highly leveraged our strategy towards the ambulatory component.
Let's talk about that, how you brought services to the community, because like in November, you took over the emergency room at Litch, at Long Island College. In 2012, you opened up the facility at 240 East 38th Street, and then you took over the extra space at 333 East 38th Street.
Starting with our cancer center back in about 8-9 years ago was really the beginning of moving out of the hospital and out of the super block and into the community. And since that time, between hospital-based practices and physician-based practices, we've opened about 55 sites in the community with 1,500 doctors who are in the faculty practice providing services, usually multi-specialty services, but closer to home.
NYU, when Bob was talking, going back with Bellevue and all the situation, most of the doctors were independent, freestanding physicians. They didn't want to be part of a faculty practice. They felt that it was easier to be an entrepreneur. Being part of the faculty practice was like being on the other side of the team. How is the acceptance today, and to have this magnitude of 1,500 faculty practice plus 700 doctors who were not faculty practice, how do they accept this type of situation?
I would say that for some it's been reluctant, and for some, particularly the ones who have trained recently, it's now the expectation. The level of regulation, the level of technological sophistication that you need to have, the number of inspections you have, the requirements in order to bill have created the need, whether you're employed or whether you're in a private large group, to have a substantial infrastructure to manage all those tasks. So most folks now want to be in a group practice. They don't want to be in an individual practice because there's too much administrative work.
I mean, you have the finest electronic records, okay? Maybe I'm biased, but, I'm a patient of your faculty practice. The system works well. I know what's over there, it's follow-up, and people are there all the time. I mean, to have medical records just for a small practice to develop that, it's too cost prohibitive.
Yes.
The malpractice insurance is prohibitive, and then last but not least, I think that the physician is going to, in the end, earn more money or receive a finer compensation because you're negotiating with the insurance companies. I mean, today, at one time, some people couldn't care about the insurance. It was major medical. I mean, the world has changed. The HMOs are really not in today, but, it's the fee-for-service.
And healthcare's changed because going back to the 80s, people were in solo practice, as Andy said. Now medicine is much more of a team sport. It's much more specialized. There's no one individual that can deliver the total care for a patient, which necessitates an electronic medical record where there's communication among the various members of the team that cares for the patient. You can't practice the way you used to.
How long is the average stay when someone is admitted to a hospital today?
Well, it really depends on
the type of thing,
so
but if you had to look at it, because at one time, the average days may have been 5.5, 6 days or so.
So if you take away the one-day stays, our length of stay is a little over 4 days, average length of stay.
And it used to be what, 7?
7, 10.
Yeah, but the average length of stay was 7 days in 2006, and today it's about 4 days. And that average length of stay should be, if anything, biased towards longer stays because you wiped out the 2 midnight rule, wiped out all the short stays.
It's interesting. I happened to have a minor procedure recently there at the institution, and I have to really give you credit because the doctor said, I'm working tomorrow and it's Saturday. And he said to me, in a way I'm angry at him, but in a way I'm happy at him. And I think, and I discussed this with certain business people, and you're at one time you were limited to bariatric surgery and certain others. Now you're doing surgery and full procedures. I got the facility. You know, I hate to say to you, you're like the Dwayne Reed. Hey, I'm paying rent for the facility. I might as well, or the food emporium, I'm open. I might as well do it.
Well, that's exactly right. So when we started in 2007, you know, we said if Southwest Airlines flew 5 days a week, they go broke, right? We have all this capacity and we ought to use it. And that actually is patient-centered because a lot of patients work during the week. They want their procedures on the weekend, right? Not only bariatric patients, but cancer patients and elective surgical procedures. Why shouldn't they be done on the weekend? The operating rooms are standing there. And so a lot of people initially poo-pooed what we were doing, but we think we've shown that it really works.
The irony was I had the surgery on a Friday. I came back for the follow-up the following Friday, and I said, so how was last Saturday in the operating room? And his comment was, you know, it wasn't such a bad idea, okay? Which is very positive because it's somebody who's been in practice a longer time. So if you can get somebody of that state and stature involved saying, hey, I don't mind because I'll take a day off, you know.
There are so many dramatic technological changes. I had a very close member of my family have a kidney taken out 4 weeks ago. Was in the hospital for 30 hours. 30 hours. That would have been a 5 to 7 day minimum length of stay as recently as 10 years ago. Now, when you multiply that towards everything, you can see that the time in the hospital is dramatically decreased, either for technological reasons or other advancements, and therefore naturally leads to trying to do this 7-day practice.
Let's talk a little bit about the ambulatory care center surgery. I mean, right now, specifically in Manhattan, you have two, you know, we have both on 38th Street, you know, over there. How many procedures are being done there, and do you plan to open more of these within the 5 boroughs?
Yeah, we currently have 8 rooms open, 4 and 4, and on one of the 4 we're adding another 2 rooms for this summer. So that's an orthopedic-oriented center, and essentially we do around 1,300 procedures per room per year. So you just do that math. Now we're up around 5,600.
So let's look at it that way. What you just said, Hospital for Joint Disease, one of the finest orthopedic institutes in the nation, at one time did the surgery on 17th Street.
That's correct.
So now, what has replaced the surgeries on 17th Street? Has it gone to 38th Street or their surgeries at both facilities?
Oh, they're still doing surgery at 17th Street. There's a demand, and the procedures that can safely be done on an ambulatory setting, we're doing. And part of it, of course, it's a combination of the procedure and the patient, right? And so if you have the right patient and you have the right procedure, it should be pretty easy and great for the patient to be done on an ambulatory basis. And what I would say is you're seeing that pressure in all the specialties and subspecialties to move to ambulatory procedures. We have just started doing ambulatory hip surgery.
That's
joint replacement.
Yeah.
That is something different. I mean, because many of the institutions, they try to get you out within two days anyway, but if you're doing ambulatory within that day, I mean, it's getting the patient better and moving over there.
Totally.
Let's talk about Brooklyn, you know, the growth and the development, you know, Cobble Hill right now and the Lutheran involvement.
Brooklyn is a borough, as you know, of 3 million people, with a medical culture up until recently that was still very much private practice, small groups. The entire borough is now consolidating, either because of DSRIP on the Medicaid side or because of big medical centers coming in, or ACOs or bundled payments. So the entire borough is consolidating. All of us are there. We've opened about 8 or 9 sites, plus are in the process of having a sponsorship relationship with Lutheran. Mount Sinai's there, New York Presbyterian's there, North Shore is there. So it will become very much like Manhattan.
In case there is a patient who has a serious condition, you'll be sending them to the lead center?
Depending on the condition. They may go to Lutheran, or they may come to...
Because Lutheran is a trauma center.
It is.
Lutheran is a level 1 trauma center. So we feel comfortable in sending patients there or sending them to NYU, depending on the patient and their needs.
Now, we were talking prior to the show that you have like 54 facilities. How are they broken down? Are they group practices? I know you have, we were saying, because I remember when you opened up in Lower Manhattan and the market wasn't there. And
right.
Now look at the number of patients you're seeing over there.
About 85% of our practices are physician-based practices, not hospital Article 28 practices, but there are some which are, and so we're broken up that way, about 85-15. We have a couple of very large programs like the Cancer Center, like the Center for Musculoskeletal Care, that are hospital-based outpatient practices. Those programs tend to lead towards that. We have a minor footprint on the urgent care centers that you talked about, but not a major one. We see that slightly different.
But as we were saying prior to the show, you see the urgent care center if it has full services, as opposed to the urgent care center, which is really a family practice, or a quickie. There was stitches or something like that, or prescribing a cold.
Or if it is doing something very minor, it will be to back up our practices and the hospital. We also like to have a situation where people can get in the same day in our regular practices and have access to full.
So let's talk about NYU today, NYU in 2017, and NYU in 2020.
The most important thing about NYU is the quality of its care. And that actually is paramount. So we have been #1 in the United States in quality and safety for the last 2 years, according to the University Healthcare Consortium. Our strategy has been all about excellence, and part of that is developing an ambulatory strategy where we bring the care to the patients. Everything is patient-centered, as you know, with the electronic health record. Our institution over to 2017, from 2007 to 2017, over 10 years, we will have added 2.8 million square feet of space. Part of that addition is a hospital pavilion, the Kimmel Pavilion. We are also going to renovate all of Tisch Hospital. So by 2020, we will have approximately the same number of rooms, all single-bedded rooms. Everybody's a VIP. And in addition, we will have dramatically expanded our ambulatory care network in all 5 boroughs. Everything is underpinned by the electronic health record and by standards of excellence throughout the entire institution.
How do we recruit the best doctors? How do you keep that they want to be there and they want to be part of the faculty practice?
So I think part of it is creating an environment where people really care. And I think the best, and part of that is your culture. And I think there is an affinity to the type of culture we have. We're a very doctor-oriented culture. We're not a business culture. And the proof in the pudding was really after Hurricane Sandy, we didn't lose a single physician. So there is a tremendous affinity toward what we stand for. Doctors want to be at institutions where they feel their patients get first-rate care. we feel very comfortable with that.
And in the same manner that Bob over here, followed a tradition that many of the people who went to NYU School of Medicine wanted to continue and stayed at NYU, Langone, or, just in general over there.
Yeah, I think there are two types of recruitment. One are people who are already out in practice, and one are people who are coming out. I think people who are coming out are looking for organizations like ours, and so we'll get our fair share. People who are already out there are looking for tools to make their transition as painless as possible. And I think we're trying to create an environment where it's viewed as a physician-friendly environment.
Yeah. I
Growth.
think it helps us, though, with Dr. Run. We're pretty much dominated by doctors on the C-suite, and we try to...
We won't hold it that we have a radiologist and a psychiatrist over here. At least we have an internal medicine.
I like to say that I'm one of the few that work in the light. But
That's a good one, in the light.
But it helps to have doctors that to some extent can identify with what the doctors on staff are doing and understand the pressures that they're subjected to.
Let's talk about the other boroughs, seeing NYU in the boroughs. Queens, where there's enormous growth. Long Island City, Astoria, Flushing. Where do you see that in the future?
Every single one of those neighborhoods, we either have a practice or will still have a practice. I'll give you an example. We moved into Rego Park about 5 years ago. That practice has tripled in size on a square foot basis, on a patient basis, and on a doctor basis. Most of them have. When you put together a group that provides good care for the community is growing.
So when we're talking about these groups, we're not only talking, it's a full service group. It's not only internal medicine, it's subspecialties and
yes.
all the
everything. We want to provide 95+% of the care that you need under that roof. Internal medicine, pulmonary, cardiology, GI, dermatology.
Now, in the same manner, are these these other freestanding facilities, are they operating on a 7-day yet? Or are they
many are on it. The one in Queens is absolutely 7 days. Some of the others are. The other thing about them is the docs and the patients in the community, if they need tertiary or quaternary care, we need to be responsive. And that's been another hallmark that we've tried to achieve. If somebody calls, if somebody needs help, we're right there.
Will you be opening up, let's say, in the same way that musculoskeletal? I know you have something in Great Neck and you have it in New York City. Will you be doing that with regard to, let's say, cancer within the boroughs and other areas? Because you have your freestanding cancer center.
Well, we have actually a cancer satellite in Rego Park. We have one in Lake Success, New York. We're opening one in Brooklyn, a second one in Brooklyn and Bay Ridge. So that is absolutely part of the plan.
So in order to grow 2.8 million square feet, to build this type of situations, a significant piece of the pie is philanthropy. How important has philanthropy been to the institution over the last 10 years? I know you had a $1.2 billion campaign.
Well, actually, we haven't formally had a campaign, but,
no, I mean,
but we've raised to date over $1.7 billion in the last 7 years. So philanthropy is very important, but philanthropy is only a part of it. The institution has to run fiscally soundly to be able to do what we need to do, and philanthropy is something that is wonderful and enabling, but it's not dependable, whereas your business is dependable.
Right. I remember a number of years ago, I was always involved in healthcare. Certain institutions, the only way they made money was the philanthropy, bottom line, helped offset the losses that they were having on the other category, right, which didn't help them when they were looking for bond ratings or anything else.
Right.
But So how are you funding the construction? Are these taxable bonds or?
So we've done a combination of cash, philanthropy, and taxable bonds.
And what's the involvement with the School of Medicine these days as a feeder and a training facility at these ambulatory care centers and so
Well, the nice part about the organization since Bob took over is that they're really integrated. So I have a role at the school and the hospital. Bob is the dean and the CEO. We're all a part of both now. We send students to most of our ambulatory sites. We continue our commitment to Health and Hospitals Corporation at Bellevue and Woodhull and Kohler Goldwater and others. But we see these ambulatory sites as absolutely critical to the future of the medical school, because that's where folks are going to end up practicing. And since the hospitalizations are so short, you can no longer train in the hospital when people are turning over.
Now, Woodhill is part of the HSC,
HHC, yes.
and you have an affiliation with Woodhill?
We have a professional services contract with Woodhull and Bellevue and Gouverneur and Cumberland and Kohler Goldwater.
Now, Kohler Goldwater is Roosevelt Island?
Kohler
Partially?
Goldwater was partially, so they moved Goldwater to the Upper East Side, East Harlem, 123rd Street.
Oh, North General Hospital.
Yes.
Yes, yes.
It's called the Henry Carter Center, so we staff that, plus we still have Roosevelt Island.
So going back to the medical school, I think and Andy alluded to this, you can't underestimate the value of having the dean CEO as one person. It has to be the right person, obviously, but the beauty of that is that everyone's aligned. You align the goals.
It's everybody's working together. It's
Everyone's
true
working
teamwork.
together. So you have your three missions of the medical center. You have teaching, research, and delivery of patient care. And our goals are defined by the dean CEO. So there's no confusion on the part of any of the chairs as to what their goals are for the institution.
So in summation, I think the NYU of 2017, 2020 is only upward and upward, as one would say, growing.
That's certainly the hope.
Okay? And I'd like to thank Bob, and Andy. Thank God I didn't have three. It would have been difficult. And I'll see you next week.